Hello everyone, welcome to another video of this revision series. In this video, we'll look for gaseous exchange. And this is a very important topic for any discussion about respiratory system. So this topic should be clearly understood. And before we go for gaseous exchange proper, first what gaseous exchange means. This means exchange of a gas from one side to another. And in case of our body, two gases mainly exchange, and these gases also exchange with one another. So the term is also reliable for this case. And the gases are, as we all know, oxygen and carbon dioxide. Oxygen is transported from atmospheric air to first alveoli, and then from alveoli to blood, and finally from blood to tissue. And the carbon dioxide transport occurs in the reverse direction, that is from tissue to the blood, from blood to the alveoli, and finally from alveoli to air. And in two places, that is from alveoli to blood and from blood to tissue, in these two sides there is exchange between these two gases, and we'll look this one by one. First, oxygen transport. During inspiration, oxygen enters from the atmospheric air to the lung alveoli. It crosses alveolo-capillary membrane to reach arterial blood. In the arterial blood, the oxygen content is approximately 19 ml per 100 ml of arterial blood, whereas in the venous blood, the content is 14 ml per 100 ml. So from this information, we can deduce that 5 ml of oxygen is getting exchanged from blood to tissue per 100 ml of flow. This is very important. Another information before we go for the proper mechanism, that is oxygen cascade, and it is all about the partial pressure of oxygen. In the atmospheric air, the partial pressure is 160 mmHg. In the alveolar air, it is 100 mm. In the arterial blood, it suddenly drops down to 95, and in the tissue it is 40, as expected, because from arterial blood to the tissue the blood should be exchanged. But why there is a gap between the alveolar air partial pressure and arterial blood partial pressure? This is due to the physiological shunt, and shunt means admixture of oxygen and carbon dioxide. So there are few sites where oxygenated and carbon dioxide bloods gets mixed, and these sites are like bronchial venous blood, which is carbon dioxide mixed blood, gets mixed with the oxygenated pulmonary venous blood. Similarly, Thebesian venous blood gets mixed with the left ventricular blood, which is oxygenated, because Thebesian blood drains into the left ventricle directly. And there is some ventilation perfusion inequality from top to bottom of the lung. Now coming to the oxygen transport of various forms. And oxygen is transported in two forms. Majority of oxygen is transported as bound form, that is called oxyhemoglobin, and only 3% is in the physical solution, that is oxygen getting dissolved in the plasma. And about this physical solution, two information should be known, that is the dissolved oxygen can easily enter the tissue, and oxygen from RBC, even before entering the tissue, it gets dissolved in the blood. So this is important. Another information, that is some clinical correlation. Dissolved oxygen plays a particular important role in tissue oxygenation during hyperbaric oxygen therapy, that is administration of oxygen at higher than normal atmospheric pressure, and as at higher pressure the amount of dissolved oxygen is increased, this alone can provide a larger proportion of total requirement of oxygen. So this is important, and this type of hyperbaric therapy is done in carbon monoxide poisoning, etc. So coming to the oxyhemoglobin part, as the name suggests, this is the bound form with hemoglobin, and one hemoglobin can bind with 4 oxygen molecules. And there is an interesting fact that when one hemoglobin combines with one oxygen molecule, its affinity for second oxygen gets increased, and so on. And this property is called heme-heme interaction, or in another word, positive cooperativity. And I have shown this in very simple diagram, that suppose this is a deoxygenated hemoglobin which is called T state or 10 state. The polypeptides are in T states, and when one oxygen molecule binds with these T state polypeptides or hemoglobin, the salt bridge are broken in the polypeptides. So the affinity for the second and thereby for the third or fourth oxygen is getting increased, and thus ultimately 4 oxygen molecule binds with hemoglobin. This is called positive cooperativity. Now coming to another important part, that is oxyhemoglobin dissociation curve. And as the curve shows, the y-axis suggests the percentage saturation of oxygen with hemoglobin and percentage saturation of hemoglobin with oxygen, and x-axis denotes the partial pressure of oxygen in mmHg. And the curve can be divided into two parts. One part, that is the steeper part, and another part is the plateau part, that is beyond the 60 mmHg. The steeper part is within the 60 mm of Hg, and in this 60 mm of Hg approximately 90% of oxygen is saturated, and above 60 mm Hg only 10% hemoglobin is being saturated. This suggests two very important information. One, that oxygen supply to the tissue is more or less unaffected in this range, that is from 100 to 60, and it explains why hypoxia is absent in high altitude up to a particular range, and that is almost 10,000 feet, and in early stage of respiratory disease. In both the cases, the partial pressure oxygen never reaches beyond 60, that is not below 60. And another important fact is that as PO2 falls below 60, even slightest drop in PO2 leads to remarkable desaturation and liberation of oxygen and making a very hypoxic condition. So this is important, and from this oxyhemoglobin dissociation curve, an important determining factor, that is P50. It indicates the partial pressure at which 50% of hemoglobin gets desaturated, and this P50 determines the right or left shift of the curve, or in other words, the affinity of hemoglobin towards the oxygen. We will discuss this. Lower the P50 means more the affinity, and that suggests left shift of the curve, and that means the oxygen is more tightly bound to the hemoglobin. It will not exchange in tissue. And higher the P50 means lower the affinity, and that suggests right shift of the curve, and it means the oxygen is not well enough to be bound with hemoglobin, and it will now exchange in tissue. So the factors that causes right shift or left shift are like right shifting factors, increased partial pressure of carbon dioxide, or in other words, lowering the partial pressure of oxygen, increased H+ concentration or lowering pH, increased 2,3 BPG, increased temperature. And interestingly, all these factors are suggestive of tissue metabolism. As there is metabolism or respiration in the tissue, all these are increased. So in tissue there is right shift of the curve. That means oxygen will now exchange from hemoglobin to tissue. And the factors that causes left shift are the just opposite to this factor, like reduced PCO2 or increased PO2, reduced H+ concentration or increased pH, less 2,3 BPG concentration, reduced temperature, or sometimes fetal hemoglobin has higher affinity than adult hemoglobin. Myoglobin also, it has higher affinity than normal hemoglobin, or in carbon dioxide tension there is higher affinity towards hemoglobin. So there is left shift of the curve. The curve will shift left side. And right shift means more oxygen delivery in tissue, as I have already told. And there is a statement, Bohr's effect. It suggests reduced pH or increased carbon dioxide tension in tissue facilitates increased oxygen release to the tissue. It is as simple as that. So this is all about carbon dioxide transport. Oxygen transport. Thank you guys.